Warm welcome, everyone, to our 2026 complete CLL course. Thanks to CLL Support Association, who's been instrumental in hosting the webinar. I will give the stage to Professor Fellows, who's going to first speaker and get us introduced into the topics.
Thank you, Nick. And it's great having Nick as our new chairman of the UK CLL Forum. He undersells himself, not telling us about his new introduction. So brilliant meeting. We're so pleased there are so many delegates signed up. And Renata and I, with the help of CLLSA, put this together a number of years ago. And it's been tremendously successful. And the discussions work really well. There's no farmer involvement. We can discuss very openly on license, off license. And having John representing the patient voice really adds to this. So please listen carefully. Get your questions together as we go. Introducing Dima is so easy. Dima, the star of the Times article, or one of the stars of the Times article, for those of you for tracking your broadsheets this week, a CLL leading light and expert at the Marsden Hospital. And we've worked very closely with Dima, obviously, over the years. And we're delighted that she's going to be talking to us about diagnosis, prognosis, and monitoring of CLL patients. Thank you, Dima.
Thank you, George, for that introduction there. So like George says, I'm going to be setting the scene for the next 3 Mondays, talking about the diagnosis, prognosis and monitoring of CLL. So as is mandatory when anyone is writing a talk now, everyone goes to Copilot or ChatGPT to help them write the talk. So the only slide that I got help with was this word cloud that I asked Copilot to design for me on CLL, and you'll see I did ask it to highlight the features associated with diagnosis and prognosis, but it came up with these all by itself. But you'll see that there is a lot that is talked about in the literature, on the internet, on all these different factors that are highlighted in red to do with diagnosis and prognosis. So whilst a lot of the talks, as George alluded to, may be driven by pharma companies, focus on the treatment of CLL and treatment choice, I think it is important to reflect more generally on some of these features that we'll talk about over the next 40 minutes or so. So I do have a number of disclosures as set out here. So just to paint a picture of the incidence of CLL before we talk about diagnosis in individuals, according to CR UK statistics that are shown here, there's approximately now 4,000 new cases in the UK per year. And this is split according to age group and also according to gender. And I don't think it'll come as a surprise to anyone that's listening to this talk that CLL is a diagnosis that is more common as people get older, with a median age in the 70s and 80s, and more common in men rather than women. At most patients, it is still identified incidentally. Patients happen to have a blood test for another reason, and a lymphocytosis is picked up. Some patients are identified following investigation for lymphadenopathy or splenomegaly, or more rarely, patients are symptomatic with cytopenias, B symptoms, or the complications of CLL, such as autoimmune complications or infections, which we'll be talking about later. And the way that I like to think about it when we come to think about presentation, but also assessing response, is that you need to think about the 3 compartments being affected or potentially being affected in CLL, whether that be the peripheral blood with the lymphocytosis, the marrow causing the cytopenias, or the lymphadenopathy and splenomegaly, so the nodal and the lymphatic system. So once you suspect CLL from the symptoms, from the lymphocytosis, then the next thing following the full blood count is to look at the blood film. And obviously in historical times, this would have been the only thing we would have had to diagnose it. And again, I'm sure many of you hematologists will know that typical lymphoid picture of these small to medium-sized lymphoid cells with that clumped chromatin, small rim of cytoplasm and numerous smear cells seen throughout the film. But of course, once we've got a lymphocytosis, the next thing we need to do is to decide from a diagnostic perspective whether it's CLL or something else. So this is kind of the algorithm when I'm in the SIH-MDS and when I'm reporting blood films and marrows there, that I think about when I'm kind of working out what the lymphocytosis is. So first of all, as per WHO criteria, because we do know that B cell clones can appear but then disappear, is that you need to define that it is persistent. Of course, most significant lymphocytoses are persistent if they are clonal, but you need to show that it's persistent, and that's defined as persisting for over 3 months. Then the next thing is it clonal? Is this a polyclonal lymphocytosis reactive to something else, or is it clonal and we're looking at more hematological causes of the lymphocytosis? So then if it's clonal, the next thing is the clonal B lymphocyte count? So you've demonstrated not just that it's clonal, I should put that it's a B lymphocyte clonal population, whether it's greater than 5 times 10 to the power 9 or less than. If it's less than, then and has a CLL phenotype, then we'd be looking at MBL, and I've got a slide on that later on. But if it's over that threshold of 5, and it has the typical phenotype for CLL, then we define it as CLL. Otherwise, of course, as many of you will know, there are other clonal B cell disorders that may have a leukemic presentation as well. So for those who don't really understand flow cytometry, this is just a very, very basic slide on it. And this is what we need for the diagnosis. So CLL can be diagnosed in the peripheral blood. And essentially what flow cytometry looks at is looking, you can incubate the cells that you've collected from the peripheral blood with different antibodies that will bind to an antigen if those cells are expressing those antigens. Those antibodies are attached to fluorochromes, and so if those antibodies stick to the cells, then you can see from the light emitted that those antibodies have stuck to the cells. And so by doing this, we can then see whether individual cells express certain antigens. So then that's how we can get all those CD numbers to see whether they're expressing those antigens. Not only that, we can look at the level of expression, see whether it's low expression, high expression in each cells. And also flow cytometry over the decades has become much more sophisticated and therefore complex, but you can look at multiple colors and multiple fluorochromes that are attached to different antibodies all at the same time. And that way you can look to see whether the same single cell co-expresses a number of different antigens. So by building up this whole picture, you can use flow cytometry to first of all demonstrate that the increase in lymphocytes, which is all that you get from the full blood count, are B lymphocytes. We use the light chain expression to decide or determine whether these B lymphocytes are clonal. So to see whether they're B lymphocytes, we'll often look to see CD19 and CD20. We look to see whether they are either kappa expressing or lambda expressing B lymphocytes, and by definition, because this is a clonal expansion of B lymphocytes, they will be one or the other. And then to differentiate CLL from other B-cell malignancies, we can look to see if they've got the typical phenotype and typical pattern of antigens. So that's flow cytometry in a very brief nutshell. And then so what the scientists in the lab look at when they're looking at the flow cytometry, amongst other things, they look at these dot plots, which is basically showing each dot is a different cell that's been interrogated, and you can see from these dot plots whether these cells are expressing CD5 in this example here, which would mean, if you can't see my pointer, that's the top left one, because these cells are all on the right hand side of the vertical line, then they are all expressing CD5. And you can see also, because they're in the top right hand corner, these cells are also expressing CD23. And so for those hematologists that are training for exams, you'll know that that's a typical co-expression that we see in CLL. In contrast, one of the main things that we need to exclude when we're diagnosing CLL is mantle cell lymphoma, and you'll see that the typical mantle cell cells are CD5 positive, so it's still on the right hand side of the dot plot, but negative for CD23. You can see that both of them express CD20, which is, as I've said, one of the markers of B lymphocytes, but what's quite typical for CLL is that the expression is lower than we might see for mantle cell. And similarly, CD200 is often another antigen that can be used to differentiate CLL from mantle cell when you're looking at a CD5 positive B cell clone. So we can use flow cytometry to diagnose CLL. Many of you may have heard of the Matutis score from my predecessors at the Marsden, who came up with these 5 important antigens, and if patients fulfilled, or their cells fulfilled all 5 of these or 4 of them, then it was a typical CLL. Those that were 3 could be a CLL, and often more atypical CLL, but those that only scored 1 or 2 were much less likely to be a CLL and to be another B-cell malignancy. Now, this score has been slightly refined in more recent years, and there is an international group called ERIC that's looking at standardizing CLL diagnostics and prognostics and assessment of markers going forwards, and they've got a minimum set of antigens that need to be seen on flow cytometry to be able to diagnose CLL, which are listed here, but they do recommend other markers to help with more borderline cases. So as you'll see from the ERIC recommendations, the first 2 are to confirm that they're B cells, the second 2 are to confirm the light chain expression and that they're clonal, and the 5th one being that most CLL is CD23 expressing. So just a quick word on the difference between MBL versus SLL versus CLL. And essentially, these are all the same abnormal cells. So if you were to look at these cells via flow cytometry, for example, the cells would look exactly the same, expressing exactly the same proteins. So the difference between MBL and CLL is all to do with just the threshold, which, is an academic set threshold. There's nothing magic about that 5 × 10⁹, but that's what's been set by international bodies in terms of diagnostic criteria. So if you've got clonal B cells in the blood, but they're less than 5, it's MBL. I'm focusing here on MBL of CLL type, but above 5 would be CLL. If patients have palpable lymphadenopathy, and that which I have misspelt, I've just seen there, apologies, and the cells on biopsy are the typical CLL cells. They may have an MBL in their blood as well, but if they've got palpable lymph nodes or lymph nodes that have been detected on CT scan, then it would be considered SLL. So like I said, when I see samples in our SIH-MDS, if we pick up an MBL in the blood, because often we don't know the patient ourselves because the bloods have been sent from external hospitals, I can't in the lab differentiate whether a patient has MBL or SLL. That needs to be correlated with the clinical information. And as I've said, the clonal B cells above 5 with the typical CLL phenotype is diagnosed as CLL. It is interesting that earlier this year there was a paper that was published in Hemisphere that I would recommend that you all read from a few of the clinicians in the UK, but also importantly a patient, and reflecting his experience of having been diagnosed with essentially a low count CLL. I think it was about 20 years ago, and he's never needed treatment, and all the emotional reaction he had to a diagnosis of CLL and a diagnosis of leukemia at a relatively young age, and all the stress that comes with going to clinics all the time. And they were proposing that maybe we should be considering changing this threshold of 5 as a differentiating factor between essentially what's a malignant disease versus a pre-malignant disease. So that's an interesting read. Like I said, I mentioned a word on MBL of CLL type. There have been groups that have stratified the MBL, and that can help us see how likely someone is to develop CLL in future years. So those that have, so we're still talking now very low B cell clones, but within the MBL, those that have a higher white count and a higher clonal count of at least 0.5 times 10 to the power 9 have a slightly higher rate of transformation, or have a rate of transformation of 1 to 2% a year. So most patients with, or most people I should say, with MBL will not progress to CLL, but with high count, the rate of transformation is 1 to 2% a year. It is incredibly low in those that have a very low count MBL, but interestingly, those patients with even small B cell clones had a higher rate of serious infections compared to the general population. So whether it's a cause or effect thing, I'm not sure, but they seem to still have some of those same immune complications, which isn't really related to the size of the clone. What I also found interesting whilst I was preparing for this talk was this paper that was looking at screening people who for MBL who have a strong family history of CLL. So they in this paper, the group screened over 1,000 people who had at least 2 family members who had a history of CLL. And they found in those 1,000 patients that about 1/5 of them had MBL. So actually, when you're looking in those with familial cases, the rate of MBL was very high. And what was also interesting was that their rate, those with familial MBL, had a higher rate of progression to CLL. So even those with low count MBL, so those that we don't expect to progress to CLL, had a level of progression to CLL that was similar to high count in those that don't have the family history, or at least are unselected for family history. So high rate of MBL, higher rate of progression. So I think that's all I wanted to say on diagnosis. So moving on to prognosis now. So I think when we talk about prognosis, even when we talk to colleagues and give talks like this, but certainly when we talk to patients as well, everyone's meaning of prognosis and what they understand by prognosis is slightly different. And some people think of it in the broader sense and think about lots of these different questions, such as how long will I live from the diagnosis? Am I going to die from the CLL? When will I need treatment? How well will the treatment work, and what the quality of life will be like? If we're looking at prognosis in the purest sense of the word from an academic perspective, then essentially we're talking about overall survival and how long will I live from diagnosis. But of course, all these questions are particularly important, and they're the questions that all our patients ask all the time, but especially when they are first diagnosed as well, because that's natural reaction and natural first thoughts once you've been diagnosed with a leukemia. And again, before we had all our genomic prognostic markers, which very much are the focus of prognostics now and helping affect what treatment choices we make, the focus in terms of prognosis was all based on clinical staging and the burden of disease and the impact on the bone marrow. And you will have all seen tables like these with the Binet and Rice staging system, with the Rice staging system looking at essentially whether patients had only lymphocytosis versus lymphocytosis plus organomegaly and lymphadenopathy, or in the later stages, cytopenias. And you can see, bearing in mind that these are old data, so this was from an era of chemoimmunotherapy, so things have changed a lot since then. But by dividing patients based on this, you could see the median survival as demonstrated, and similarly, the number of nodes correlated with median survival, and again in the Binet system, cytopenias being associated with the shortest median survival. But as I say, we've got more sophisticated ways of assessing prognosis, but also things that might help dictate treatment choice, and obviously treatments have changed dramatically since when these survival data was collected. So now we have got a plethora of different ways of assessing prognosis, whether that be fission cytogenetics, mutations. I think we moved away from using some of our flow cytometry assessments that we used to use for prognosis, such as SAP70 and CD38. And then there are other things that perhaps we see in different scientific papers looking at methylation profiles, microRNA, telomere length, that have all been shown to be associated with prognosis. In terms of what is most used clinically at this moment, I'm going to focus on the ones that we recommend in guidelines. So both the British guidelines, but also international guidelines, are the ones that we should be looking at. So IGHV rearrangements, and then looking to see whether patients have got an aberrant TP53. So if we focus on IGHV first of all, so IGHV, when we're categorizing patients with CLL, can either be unmutated or mutated. And essentially, to understand this, you need to understand or recall your immunology lectures from medical school about normal B cell development. And just to remind everyone, as you all are aware, your B lymphocytes, like all your blood cells, are made in your bone marrow, but they mature in your lymph nodes, and so you get your naive B cells that have been exposed to antigen and then have in the germinal center within the lymph node undergo a series of different changes, including somatic hypermutation in the variable regions, leading to a change in affinity for antigen, so that you get B cells that are naive to B cells that have been exposed and can react therefore in future to antigens, and have been undergone this process to increase their affinity for that antigen to be able to improve tackling with infections. So CLL essentially could be considered two separate diseases, and if we were classifying CLL now, indeed we may have divided them into two different diseases. So CLL can either be due to a malignancy of the unmutated or B cell, or naive B cell, I should say, or they could be B cells that have undergone this somatic hypermutation and could be mutated and are more mature. So those that have mutated IGHV, the cells are more mature, and the disease, and so therefore that's how I think of it, that's the reason it's more indolent, that those cells are less capable of dividing, and therefore patients with CLL that is IGHV mutated are more likely to not need treatment at all. There's certain treatments where we know that they are likely to have better outcomes than those with CLL that is IGHV unmutated. mutated. Now, there are some treatments where it doesn't seem to make a difference what the IGHV status is. The outcomes are quite similar, but there are certain treatments, and particularly the fixed duration therapies, where we know those with IGHV mutated disease are likely to have better outcomes. And those patients with mutated IGHV CLL are more likely to die from causes other than their CLL, whereas in contrast, those with unmutated IGHV CLL are more likely to need treatment, are more likely to need treatment sooner. It has been shown in some groups to be associated with overall survival. Of course, though, all these data looking at overall survival in CLL it is often historical and based on an era of chemoimmunotherapy, and things have changed now. And familial cases tend to be those that have IGHV or unmutated disease. So what I would say is what the BSH guidelines suggest is that as soon as a patient is diagnosed, their IGHV status is ascertained, because this is something that doesn't change. So once you know whether it's an IGHV mutated or unmutated CLL, that's going to be the case throughout. And it may help you discuss with the patient and potentially affect how often you see the patient, whether they've got unmutated or mutated CLL for IGHV CLL. So it's worth checking at the beginning. One thing to note, though, is that we use this binary kind of cutoff of 98%. So comparing the CLL IGHV to the germline IGHV, and if it's more than 98% homology, then it's unmutated, and less than, so the more different it is, then it's mutated IGHV CLL. But it's probably, this variable is a continuous prognostic marker, so the more different it is to the and more mutated, if you like, it is to the germline, then the better the outcome. So mutations and deletions of TP53 are also very important prognostically, but these are ones that can be acquired with time. So partly because of that, and partly because actually there have been more recent studies that seem to suggest that it doesn't, it's not associated with time to first treatment. We don't tend to, our general practice in our HMDS is not to assess TP53 status until patients are approaching therapy, because, you know, even if you check it at diagnosis and they have a normal wild type TP53, then they may have acquired a mutation or a deletion by the time they need treatment. And also, if they do have an aberration in TP53 at the point of diagnosis, then it can lead to unnecessary worry, because, you know, people read about the data and the prognostics and are aware that those with a TP53 aberration often have less favourable outcomes. So we tend to check it at the point of treatment and at each line of therapy, because, as I say, it can be acquired. And so TP53 can be impacted in two different ways. So there can be a mutation in the gene itself, which is picked up from molecular studies, but there can also be a deletion of 17p, which is where the TP53 gene resides, and that often is picked up by FISH, but there are also molecular assessments that can pick up 17p deletions looking at copy number variations. So the most common way that we see when patients have CLL that has an aberrant TP53 is that they end up having no functional TP53, and that on the most common combination is that the patients have a 17p deletion on one chromosome accompanied by a mutation on the other one. So those are the two that I wanted to mention in terms of what we assess and what we recommend is assessed in the UK. And like I say, international guidelines suggest the same thing, because that can impact treatment choices. But of course, from a patient perspective and in a clinic, people want to know, like I mentioned on that slide, in terms of what prognosis means. They want to know, once they're diagnosed, how quickly are they likely to need treatment, because, you know, everyone wants to plan their life, understandably, and there are many different prognostic scores, and I could spend the next few hours talking about all the different CLL prognostic scores that have been created, but I'm not going to do that. I'm going to highlight a couple of the ones that I think are quite user-friendly and that are that have been extensively investigated. So one of them is this time from diagnosis to treatment, and I think it's IPS score, and it's a very simple tool looking at just three variables that we would be checking. Does the patient have unmutated IGHV? Are their lymphocytes over 15? And is there nodal involvement? And so essentially you get a score between 0 and 3. And then those that have got a score of 2 or 3 are considered high risk, 1 intermediate, and none of those are low risk. And you can see that the likelihood of needing treatment if you've got IGHV mutated disease that is less than 15 and with no nodal involvement, less than 15 the lymphocyte count, that actually at 5 years from diagnosis, less than 1 in 10 of those patients have required therapy. And you'll see, and this is looking at quite a large number of patients, so just under 5,000 patients, that you'll see that there are many patients that aren't needing treatment 20 years out from diagnosis. Intermediate risk, you're looking at about just under a third of patients needing treatment within 5 years, so still the majority of patients not requiring therapy, whereas those that have at least 2 of these points are much more likely to need treatment. The majority actually not within a year necessarily, but the majority by 5 years requiring therapy. So interestingly, as I said, TP53 wasn't predictive when they had analysed that variable to create this score. So this can help you inform the patient in terms of likelihood of needing treatment, but also could, as I say, affect how often we need to follow up patients in the clinic. So the CLL IPI is also quite a score that is often collected for clinical trials, and that was based on assessment of about 3,500 treatment-naive patients, looking at 5 prognostic factors: so TP53 status, IGHV, serum beta-2 microglobulin, the clinical stage, and whether their age was over 65 or not. And these were weighted, so certain factors could score more points, such as TP53 and IGHV, but by collecting all of these, you could get a score and divide patients between low and high risk. And you can see that this CLL IPI predicted for first treatment according to risk group. So those with the lowest risk are very unlikely to need treatment, but also it predicted for overall survival. Now you can see that this was published in 2016, and so this was reflective of the chemoimmunotherapy era when we're looking at overall survival. So there's been another group that have published more recently whether the CLL IPI retains prognostic significance in a more recent era of targeted therapies. And so you can see that panels or survival curves A and B are the progression-free survival and overall survival curves for patients who had targeted therapies as their first line of therapy versus C and D for those who had chemoimmunotherapy. So CLL IPI retains significance for progression-free survival with targeted therapies, but the overall survival curve was much more bunched up. And if we translate that into percentage who are still progression-free at 3 years and overall survival at 3 years, percentage that are still alive at 3 years, you will see that there is still a stepwise reduction in those that are still progression-free according to risk category. But just look at those numbers of progression-free survival compared to the chemoimmunotherapy era, where just 16.5% of patients were progression-free at 3 years if they were very high risk, compared to now 79% of patients still being progression-free, even in that very high risk group. So I think it does emphasize how much of a game changer targeted therapies have been for those patients, particularly that have more high risk prognostic features. So there are other genomic changes that have been reported to be associated with prognosis, but I think one thing to think about, and this isn't an exhaustive list, but some of the more common ones that are picked up, and certainly we report them in our NGS panel in our HMDS too. But it is important to think about these, that they're not necessarily in isolation. So it's often hard to pull apart if someone has IGHV mutated disease, for example. If they've got a TP53 aberration, it doesn't seem to be such a bad prognostic marker as those that have IGHV unmutated disease with a TP53 aberration. So I think knowing all these prognostic markers are all very well, and when it's simple when you're just looking at one in isolation, but when we start putting them all together, it becomes very complicated to understand them all. And then the other thing, and I'm not really going to dwell so much on predictive markers. So when we talk about predictive markers, we're looking at mutations that or change factors that will predict for a better or worse outcome with certain drugs. It's also worth thinking that it's not just about the prognostics of the CLL, but there are also patient-related factors that can have a major impact on prognosis. So I'm just going to highlight one real-world study here that was looking at patients using or taking ibrutinib for their CLL outside clinical trials, and the reasons that they might either reduce or stop their drugs because of toxicity, but also impact on survival, to see what prognostic markers impacted that. And if we focus on the right-hand side of this slide, what impacted survival, apart from those that we would think would be from a genetic perspective, so the TP53 aberration impacted PFS, EFS, and overall survival. So did the SEER score, so did the ECOG, and so did whether the patients had neutropenia or not. So it's not just the CLL related factors that can impact prognosis, but also patient-related factors as well. So then the last few slides are focusing on monitoring. So what do we mean by monitoring? So for me, when I think about it in different stages. So there's the monitoring of patients prior to starting therapy, when you're really looking to see, does this patient have an indication to commence therapy? For those patients on therapy, we're thinking about monitoring the toxicity of treatments, but also how effective the treatment is, and whether that be the depth of response and the MRD, the durability of the response, and then starting to think about when the treatment is no longer working and patients are progressing, what our plan is in terms of further therapy and whether we need to reassess prognostic markers. And then the third thing that we always need to think about when we're monitoring our patients in clinic are the complications that are either directly due to the CLL or are associated with the CLL. So monitoring for infections, monitoring for other malignancies. So if we think about looking for an indication to commence therapy, there are international consensus criteria for commencing therapy. These are just guidelines. And these are the recommendations that they suggest for when you might want to consider starting therapy. For me personally, I don't focus just on these, and the main thing is, from a patient-centric perspective, is is the patient getting symptoms related to their CLL, and do I think treating it will make those symptoms better is at its most basic. I mean, obviously the two overlap massively, but that's generally how I tend to think about it. And the IWCLL guidelines suggest monitoring patients in the first year every 3 months with a history examination, full blood count, and then thereafter every 3 to 12 months, and potentially you could stratify patients according to risk as to how frequently you're going to see them. This was a paper that was published recently that I thought was quite interesting to see whether actually patients benefited from specialist follow-up as opposed to being discharged to community practice if they had very benign or indolent or low volume CLL. And so this wasn't a randomized study, but it was looking at if patients had a low CLL IPI, so therefore had a low chance of requiring therapy, and they created this CLL won't score as well, then the clinician and the patient could decide whether they were going to continue specialist follow-up or end specialist follow-up. So these were patients who had only low risk or intermediate risk CLL for progression. And you'll see that actually, paradoxically, we like to think that we're adding benefit to our patients, but those patients that ended specialist follow-up had better outcomes in terms of overall survival than those that continued specialist follow-up, sorry. Now, of course, this wasn't randomized. There may be more reasons why people are kept under clinic rather than discharged that may explain this overall survival change, but it is interesting to see this. I'm not going to go through the response criteria when patients are on therapy. This is part of the IWCLL guidelines for assessing response. I think it is worth remembering that response assessment, whilst it's very important for trials and capturing how effective drugs are for trial purposes, to be honest, I think from an everyday clinical purpose, maybe has less relevance in terms of kind of knowing the difference between a PR and a stable disease, I don't think there's a true difference clinically if someone has a decrease in their lymph node size from 50% versus 49% reduction, but you have to put the cutoff somewhere for a trial. So these are there, but I'm not going to go through it in detail, but largely in terms of response assessment, we're looking at those 3 different compartments. So is there still a lymphocytosis? What's happened to the nodal distribution of the disease, and what's happened to the marrow function? So that's broadly how response assessment is categorized. And as I say, for me, from a clinical perspective, it's more important to see the blood counts improving and the symptoms improving, because that's why we gave the treatment. Of course, every trial now has a focus on MRD, and I'm sure over the next 2 weeks there'll be a lot of talk on MRD in the discussion of the different trials for different treatment options. But it's worth thinking that MRD, the ERIC guidelines suggest that we should be calling this measurable residual disease rather than minimal residual disease, and that there may be different reasons why we would look to assess MRD. So we can use it as an assessment of the depth of response. So if we can pick it up with our MRD tools, if we can pick up evidence of the disease, that may correlate with prognostic information and may help us predict relapse if we start seeing MRD recurring, but that it may be predictive of the duration of response, but also, as I'm sure we're all aware from the FLAIR study, may help us dictate duration of therapy. So for those patients who develop undetectable MRD quicker, may be able to have a shorter duration of therapy than those who have more disease that is more detectable for longer periods of time, may benefit from longer periods of therapy. So there's a lot of discussion on MRD, but I think that it will become more complicated with time as we understand more about MRD. There I think when we're thinking about MRD, it's not a one-off test that's a binary test. And when you think about MRD, you should think about three different factors when we're discussing and comparing trials. What the sample type is, whether it's peripheral blood or bone marrow, because you're more likely to pick up low levels of disease in the bone marrow than you are peripheral blood. The method of analysis, so whether that's flow cytometry, allele-specific PCR, or NGS, and the depth of analysis that the test goes to, so whether it's 1 in 10,000 or 1 in 1,000,000 cells, and that this can all affect whether we're calling something detectable MLD versus undetectable MRD. And that can make a difference to all those things that we've talked about prognostically. I'm just going to briefly mention a couple of trials where MRD has been shown to be, that has been presented. The first one was CLL 14, which led to Ven-O being licensed as a fixed duration therapy for those that were treatment naive. This was in the older age group, so the comparator arm was obinutuzumab and chlorambucil. But if we focus on the blue lines on the survival curve, you'll see that those were the patients that had Ven-O. You'll see that those that achieved undetectable MRD at the end of treatment had a much longer time to progression than those that had persistent detectable disease at the end of treatment. So MRD assessment at the end of treatment with Ven-O is very predictive of the likelihood of early progression. We also know in the combination between ibrutinib and venetoclax so GLOW study was looking at I plus V in the older age group, and again, so randomized to chlorambucil and obinutuzumab. And so in those patients with IGHV unmutated disease, those that achieved undetectable MRD had a longer progression-free survival than those that still had detectable MRD. But that discrepancy between MRD wasn't so apparent in those with IGHV mutated with the more favorable disease. So MRD was less predictive for those with IGHV mutated disease. As I said, in terms of monitoring, we need to monitor for other malignancies as well. And this was, I thought, an interesting article looking at malignancies that were diagnosed in patients who had CLL that were diagnosed either before their CLL or after their CLL or after therapy. And you'll see, as we know, those with skin cancers, those with CLL have a much higher risk of skin cancers. There are certain cancers that are more common anyway, so breast cancer, prostate cancer, that we see in a lot of our patients with CLL, and we can identify those. But that their hematological malignancies and lymphomas are far more common in those that have been diagnosed and treated for CLL. And then the other thing about infection and monitoring for infections we will hear about in the next talk. So I'm going to end there, and sorry for talking too much.
No, Dima, thank you. That was a wonderful talk. I already feel guilty for having cut across you there. But I know the panel discussions are so sought after, and I've kindly got permission, we're going to run over 5 minutes so we can get a bit of debate. There are key areas around diagnostics, workup in day-to-day life, prognosis, all these things. I'm going to put you on the spot and I'll hop around the panel. So the first thing, diagnosis, Dima, we come across low-level lymphocytosis from primary care so commonly coming through our hospital labs. Is it right or wrong? Because there's such a variation across UK practice, whether we just accept, they're 78 years old, the lymphocyte count is 6, the film's got smear cells, likely early stage CLL, refer up for phenotyping if clinically indicated. Or do you think we should be phenotyping every time we see a lymphocytosis? That should be just a UK practice.
My personal feeling, especially having read the article for those that have got CLL and the connotations of that, and as you say, low level is probably not going to impact them, that probably we shouldn't be routinely checking and therefore diagnosing and over-diagnosing and over-worrying patients. I think there need to be kind of robust mechanisms that it's been alerted that there's a possibility, because obviously these things can change, and there's a one-off snapshot's not going to predict what's going to happen in the future. But I don't think we should be over-diagnosing patients with low-level lymphocytoses.
Let me bring John in. Thank you, Dima. So, John, through a patient, you imagine patient perspective, you're in primary care, you get bloods checked. And of course, there are very different situations. There's the ill person with multiple things going on, and just adding one extra thing is a nightmare. And then you've got your fit 78-year-old who genuinely wants to know, what's your patient view on over-testing or under-testing?
George, the day, and talking to all the patients as we do, the day that you actually get the news of your diagnosis is classed as today is the first day of the rest of my life. So it's a pivotal day. It's akin to where were you when JFK, Princess Di, or One Direction broke up? It's depending on what age you are. That's the significance of it. But changing the threshold, as Dima mentioned, for the diagnosis, I think that's a really interesting and encouraging perspective because it's such a significant pivotal point in your whole CLL story.
Okay. Well, thank you for telling me One Direction had broken up. Going back to Dima, sorry, the other key thing about the prognostic data, you're saying that, John, I will be bringing you back in and I'll pick on Renata as well, is when do you deploy that prognostic information? Because we in our trust are not doing the IGHV mutated for the early stage. We're not running the FISH panel. And yet you put a cogent argument together that actually running that data might influence how you follow people. Should we be doing that on every patient now?
We do it on every patient. We do it also on our MBLs as well. So if we pick up a CLL clone, we will run it because I think it does provide information, as I said, in terms of whether we should be following these patients up or not.
Okay. So Renata, in Bournemouth, are you running? Actually, Bournemouth's very molecular orientated. I should be asking Nick, but go on, I've asked you now, Renata.
Yes, I do. I do check similar to Dima. I do check for IGHV because, as Dima says, if somebody has got a pretty low count mutated, I'll discharge them almost on the spot, reassure them, and in a way, I think I'm giving back that best day of their life. Just suddenly by maybe
One Direction
and back again.
Okay, so I take that point, and I like that Dima really drew out that 3-point scale that is so easy, and I must admit, I keep hold of that as well. Lymphocyte 715, you've got palpable lymph nodes. I think in the actual data set, was it over 1.5 centimeters? I can't remember. Yeah, I'm mutated versus unmutated, very powerful prognostically, so I definitely buy into that. I guess, John, flicking straight back to the idea of prognostic information early on from a genomic level, from a patient perspective, you talked about the beginning of the rest of your life type thing. Knowing prognosis before you start, particularly the concept that actually this is big population prognosis, and we must reflect on the fact that 20% of the 3-point score are still untreated at 10 years. So it's not predictive. I love the way Dima went into predictive versus prognostic. John, what's the patient feeling about that, do you think?
Well, first of all, George, as you probably well know, you can be overwhelmed with information, especially on the day that you're diagnosed. Your power of receipt of information that day is probably very, very slim. I always remember Chris Fegan in Cardiff saying the most valuable consultation was the one shortly after the initial consultation. That's when the patient is more receptive. Then, because of all the media attention to cancer diagnosis and early treatment that is just about these days, people are much more open to sharing. The natural feeling is, I want early treatment. I want to know all I can know about my chances. But there's equally a bunch of people, a patient cohort, who want to know very little. And it's a matter of judging who's in which cohort. And then I think the appropriate timing of all of the tests that are available and the costs of those tests. I mean, as a patient, we have to be cognizant of the cost of those tests. And
it sounds like it's very cheap running your service at Marsden. I mean,
so, it's it is not one size fits all, and I hate to use that cliche, but it is true.
Thank you, John. Yeah, I do think with molecular testing, there's a huge variation between the individual patient. Before I leave you, John, thought-provoking, get discharged, you live longer. Surely selection bias on that. It's a patient and clinician between, it's those happy-go-lucky, look, nothing wrong with me, off I go. They must live longer than the people who have got things wrong with them and the doc keeps hold of them. Yeah.
If I had eyebrows, they would have been raised at that point.
Okay, David, I'm bringing you in as our resident immunologist. I know you're going to be talking about infection, but Dima did remind us of that tantalizing data that basically having CLL clones in your body is probably not good for your immune system in terms of infection and problems, etc., etc. Would that ever justify a clinical immunologist seeing our CLL patients, even in early stage, as a one-stop shop? Because I do not feel particularly equipped in this day and age to deal with complex infection-related issues. Should we be bringing your skill set in earlier and broader?
Well, yes, absolutely. I would, of course, volunteer, and we're always looking for business. But yes, and in fact, I will cover some of this in my talk, but I think you're right. So, I mean, even in people with MBL, and I say MBL in my world is managed binding lectin, but I know that it's a different definition here. But people with MBL from a hematology definition, we definitely see some of that group of patients who do suffer recurrent and significant infections, and people with pretty early stage CLL. And I will cover some of this in the talk. We definitely see a strong infection phenotype, and I think that very often does need attention.
But I guess, David, there's also this selection bias because you are seeing the tricky CLLs that have been sent to you. I mean, it is, well, as clinicians seeing a lot of CLL, you really do get that sort of 50-50 feel that some of them just don't get infected. Even the hypogamma ones, they come in, you can say what you like about my numbers, I'm just not getting infections. And others who, honestly, they just go out once to the shops and they come back and they're in bed for a week. And it is so variable. Anyway, we do need to keep moving. We will come on to infection. Nick, I haven't forgotten you. I'm going to put you on the spot with this one. And it is a bit of a bugbear with mine. And Nakib has asked a great question, but she did say, thanks, Dr. Dima. And I was asking Dima, but I'm going to Nick. When exactly should we do bone marrow aspirates and CT? Should we do this at first diagnosis, approaching treatment? And I'll give you my clues about what I think about regular bone marrows in CLL. Not positive. Nick.
Yeah, thanks, George. Well, it'd be interesting to know what John thinks as a patient about bone marrows. I personally think the least the better in general. The painful procedures, although they're relatively simple, and unless there is any specific question that you need to answer, I wouldn't routinely use them. Though, what would be those specific questions? Sometimes people can have dual pathology. So when there are two different clones in the peripheral blood, then there's probably a mandate to do a bone marrow to clarify what's going on. People with atypical phenotypes, because they can have with lymphocytosis with atypical CLL phenotype, sometimes they can end up being non-CLL, and you might be mistreating those patients. And the other situation where I do bone marrows is where there is a discrepancy between what I'm seeing in the peripheral blood in terms of the size of the clone and what's happening with either symptoms or the other hematological parameters, so disproportionate anemia, disproportionate platelets, where you need to know what's going on, and having an accurate measurement of disease burden in the bone marrow before treatment is useful. Apart from that, very little. And
mandated in a clinical trial.
Yeah, and we have demonstrated in trials that the correlation between MRD measured in peripheral blood and bone marrow is not perfect, but is good enough probably for prognostication. So that's also not enough justification. And with regards to CT, I think I do want a baseline because some people might have a more synodal phenotype that you want to follow up over time. And depending on that initial result, then you plan to either scan with certain interval or not at all if there's nothing. So I think CT's kind of at the beginning is quite useful because I've learned to rely less and less on my the accuracy of my clinical examination, because sometimes, yeah, seriously, and sometimes I tend to I tend to overestimate, and I've heard colleagues that tend to underestimate the size of the lymph node. So it's difficult, and sometimes it's useful to have accurate measurements.
But so I think you raise an interesting point. I think there's been a big practice drift. So the 20 years I've been running a CLL clinic, from very rarely doing a CLL, and I wonder if it's because we're all lymphoma doctors as well, so we're so comfortable with sending for a scan. I think tumor lysis assessments means we're doing them more and more if there's any venetoclax around. And then the end of treatment, defining the baseline for the future. It is simply useful because you've got a reference point. So I can very much see why CT has just crept into our practice. Our poor radiologists cursing the number of scans we sent through. And I don't know, is it right to feel easier about exposing a patient to radiation than exposing them to the discomfort of a bone marrow? Don't know. They are older patients. Perhaps second cancers in 20 years' time, perhaps not as important as the pain at the end of that needle. But I think it's unfair comparing the two. Now, we are literally got 1 minute left of questions. Dima, are there any other summary points you want to bring back to us? I'm just checking. No, another question have we got? Follow-up question. Do we need CT to look for lymph nodes? There's nothing palpable. So I think we sort of covered that off a bit. I think in routine practice, you don't necessarily, but most of us, if you're taking someone into treatment, you're going to probably get a baseline CT. Probably fair comment. Oh, John, yeah, sorry.
I had just one comment on Dima's presentation. You talked about academic prognosis didn't include quality of life. From my perspective, I would like to see that included because I think that's important.
Yeah.
Yes. I did mention it, that patients ask, and it is an important factor, but you're right, I didn't elaborate on that. And it is a very important thing that is badly, I think, collected in clinical trials. But I think hopefully there is a focus, particularly with patient engagement and PPI involvement in trial design, that there will be more of a focus of that going forwards.
Yeah.
Thank you.
I liked your comment about performance there. You were talking about SIRS scores and being overall prognostic. And years ago, John, you might remember from the CLL Forum when we were looking at ibrutinib, the biggest separation of actual true overall survival curves came from performance status. And I think that is a general reminder to us that we're obsessing about CLL prognostic things. Then Dima rightly pulled out that if you are predicting in that individual, so much about their comorbidity profile and everything influences how we think about them. There's not detracting from your quality of life comment. So Dima, we're now 6 minutes, top of the hour. Summaries, any final points you want to bring to us about day-to-day practice that we should take home as messages?
So I think we've gone through the diagnosis. CLL is quite a clear-cut, usually diagnosis, although there can be borderline cases. I think that where the field is changing with time is prognosis, and we want to change prognostic markers into predictive markers and to dictate what choice of therapy we give, because none of us want to tell someone you're in the worst category or the highest risk category. We want to be able to say, we want to give you this treatment because we know this one's going to work better for you than an alternative. So the field is moving from hopefully prognostic markers to predictive markers. And then I think there will be a lot going forwards in terms of monitoring, like we've highlighted quality of life, but also I think MRD as well.
Fantastic, Dima. And on that note, we have no more questions in the chat. I will hand over to Renata for our second session.